I'm excited to announce that the Shortcoat podcast has now joined the MedEd Media Network at mededmedia.com. The Shortcoat podcasts are broadcasts from the amazing and intense world of medical school from the students at the University of Iowa, Carver College of Medicine. Go check them out directly at theshortcoat.com. This is Specialty Story, session number 12. Whether you're a pre-med or a medical student, you've answered the calling to become a physician. Soon you'll have to start deciding what type of medicine you'll want to practice. This podcast will tell you the stories of specialists from every field to give you the information you need to make sure you make the most informed decision possible when it comes to choosing your specialty. My name is Dr. Ryan Gray, and if this is the first time you are joining me, this is not how my voice sounds normally. I just got back from a long podcasting conference, and I talked the whole time. And now my voice sounds like this, and I think I have a cold on top of that too. So I apologize, but that's okay. The show goes on. I just want to mention one more time that the Shortcoat podcast, which is an amazing podcast put on by the students at the University of Iowa, Carver College of Medicine, is now part of the MedEd Media Network. Go check them out at theshortcoat.com. Today's guest on Specialty Stories is a solo private practice facial plastic surgeon. It's a great specialty, super subspecialized specialty of ear, nose, and throat surgeons, or otolaryngology. And Victor, or Dr. Chung, is going to join us and tell us all about it.
My name is Victor Chung, and I practice facial plastics and reconstructive surgery as a subspecialty of otolaryngology, ear, nose, and throat surgery.
What type of setting are you in? Are you academic or community setting?
So I'm actually one of the rare breed private practice, truly private practice, solo by myself, the only physician in the office. And it's an interesting kind of hybrid situation where as a specialist, I am affiliated with a number of the hospitals in the San Diego area. However, I'm not, officially on staff, like in the hospital, always there all the time. But I do consultation and coverage for call and operate at those sites.
What made you decide to go to the private practice route, since it seems like the majority of physicians are pulling away from that?
Yeah, that's an absolute truth. Out of all the fellows who graduated my year, only 2 of us went into true private practice and opening practices. The majority were either joining multi-specialty practice groups or, and even looking for academic jobs was a tradition, and that's falling by the wayside. My personal reasons is I had phenomenal training, and I wanted to practice medicine the way I was trained to do it. And when you become part of a bigger group, and that may be a partnership, even as small as that, there's a level of compromise. Otherwise, there's no way for you to be successful. You can't do everything your way and expect the other person to do it, and you can't have someone else expect you to do everything their way. And so to have that choice, that freedom to practice without restriction, in a sense, delivering care the best of my ability, ordering the more expensive supplies, equipment, or employing a technique that's that I know how to do well, then that choice was natural for me, in the sense that I had the luxury of being in a great personal situation that I could do that. So it's not a complete compromise when you join a bigger group, you join academics, but a lot of times you find that your patient population or your group that you're in, the environment will dictate your niche and your future, and you may start doing things that don't make you necessarily happy anymore in medicine, and you start doing fewer of the cases that you like to do, or take care of the patients that you like. So you can find that ideal situation in academics in larger groups, but it's just more challenging.
Okay. How long have you been out in practice?
So I've been out in my own practice, officially doors open just over 12 months. It took me a number of months just to get my place set up. A lot of logistics and a lot of things they don't teach you in medical school or residency or fellowship about applying for business licenses and insurance and all the other types of regulations that are necessary to own and run a successful and safe business.
When did you know you wanted to be a facial plastic surgeon?
I don't know if there's an exact point in time. In medical school, I always knew I was going to do surgery. Enjoyed that aspect of thinking, the hands-on aspect of it, the culture, the lifestyle. That was all agreeable to me. Now, honing in into a particular specialty was tough. I was looking at a number of subspecialties that operate in this area: ophthalmology, neurosurgery, plastic surgery, craniomaxillofacial, and ENT. And when it came down to it, I found that ENT subspecialty really appealed to me because there were so many aspects that were different, even within a singular focus of the human body. It was challenging, and facial plastics is, although a subspecialty within it, it's still an integrated part. You'll go out and in the community and meet physicians who are ENT trained but not fellowship trained, but they are still practicing as facial plastic surgeons, and that's encouraged by the overall academy. And those types of procedures can be, reconstructing cancer that have been excised on just a skin level, but others are doing larger reconstructions or rhinoplasty and facelift based on their skill set and their comfort level. And I find that the ENT specialty overall gives you all the skill sets you need, and as an individual, you get to pick the things that you are comfortable with or you really enjoy doing and focus on those. And oftentimes you'll meet other physicians in your community who like doing the other procedures that you may feel less comfortable with or ones you don't like doing as much. And so there's a good camaraderie that goes on there, and you're a lot happier treating the disease states and doing the surgeries that you like to do.
What traits do you think lead to being a good facial plastic surgeon?
It's a very particular skill set, because you're talking about someone who needs to be both left brain and right brain. You need to be analytical and very objective in a sense, and understanding proportions and direct measures and changes in that sense, but also someone who has an artistic component in how they think about things, how they view things. And so when I perform a rhinoplasty surgery, I am not only looking at this overall picture. So, it's just not just the nose and a good shaped nose, but I have the entire face prepped in the field and exposed. I'm looking at the relationship of the nose to the chin, the forehead, proportions to how wide the eyes are, and that overall aesthetic. But in addition to, as a confirmatory measure, I do all these different measurements: how far the nose projects out, the angles, and those are fit within accepted values. And so you need to be able to combine both sides and not be locked into either one, and be able to produce something that people have to. It's right in the middle of your face. Is very obvious. So I think the stakes are a little bit higher.
As you came down to the decision to go into ENT, were there any other specialties that were close in the running, or had you made that decision at that point?
I actually had not picked my residency, specialty until very late in the process. I'd gone through most of the clinical clerkships of my third year, thinking that I was leaning toward maybe orthopedic surgery. It's just a specialty within surgery. I didn't think I was going to do general surgery, but I did know it was some sort of surgical hands-on going. But at the time, also interventional procedures are getting big. Interventional radiologists and cardiologists, they have very hands-on, very three-dimensional stereotactic type specialties as well. But when I was thinking about which one to hone in on, I didn't get that exposure until in maybe the last quarter of that third year clinical clerkships. But it did turn around, and I just got to interact with some very stimulating cases at the same times as very nice residents who were open to sharing what they were doing and allow me to participate, and inspirational attendings. And so it always happens to be sometimes that magic combination. But I always tell students who are trying to figure out what they want to do for the rest of their lives that you can't just base that purely on a good experience. You need to figure out what is the day-to-day kind of drudgery. What are the patients that come in and can be on the side of, some people say, painful or take up extra time, and make people sort of shudder at thinking like, oh no, I'm going to see a bunch of those today. And see if you're okay with that. And in the specialty of ENT, boogers and earwax, that's what I tell people. Like, if you have no problem with those bodily fluids, then you'll be okay. Some people's aversion is blood. Other people it's they don't like eyeballs. The other they don't like stool. That's not. So you got to kind of pick what you are comfortable with seeing day to day, because if you don't like your day to day, you're not going to enjoy the highlights anymore. And so I tell students all the time that check out the really dizzy patient that is struggling and you can't get a good exam on, but you still trying to figure out how to treat them. Spine surgeons, they have low back pain. It's really, really tough sometimes to figure out if they're surgical or non-surgical, and yet they can take up more than a full appointment visit. So each specialty, I tell students to examine, find those highlights, but also find, what are the low points, and if you're okay with those.
Yeah. What types of patients do you treat?
I see all kinds of patients, and that's what it really keeps me captivated and stimulated in my specialty. It goes from very minor, very cosmetic. There's no medical emergency about it whatsoever. There's no urgency. It's purely elective. The changes are super subtle, super small. There's no life-threatening thing that you're changing, and yet people gain quite a bit of benefit from them. Attitudes change, self-esteems improve with a subtle thing that bothered them that maybe no one else noticed. But on the other end, I'm still participating in general ENT call. I'm doing tracheostomies for people who've lost their airway. I'm doing reconstructions for people who have lost major tissue from skin cancers or other disease or trauma. And so, and those are very drastic changes, to improve someone's function. And, there's very little cosmetic aspect of that. And so I like that spectrum. I don't think I'll ever really give up doing all those things. I don't do much for ear tubes anymore. That's probably the most minor surgery you can do. But I like that full gamut of complexity and simplicity, and, because you can gain benefit for your patient on both ends.
Describe a typical day for you.
Well, being new in my practice, every day is pretty variable at this point in time. The idea is it is a clinic, private practice-based practice, and so the majority of my patients would be seen in the office setting in a combination of consultations, follow-up visits, minor procedures, injections, injectables, those types of visits, all in the office. And that'll be, as the trends go, more and more surgeons are doing things in the office. Typically, a surgeon in my specialty will have block time or days set aside what they were operating, maybe 2 days of the week, being in the operating room, doing a number of cases. And the majority of them would be on the outpatient setting in my specialty. And so most of those patients are going home. But, a select amount would be seen in the hospital as an inpatient and seen on multiple visits in the hospital before they're released. So, but in addition to that, what a lot of people And a lot of students and a lot of doctors don't realize there's the business side of it. And so you can fill an entire day with administrative tasks, but it is about prioritizing and compartmentalizing. So I do pick one night a week where I have a late night, and I don't go home until everything on the administrative side is done. And the rest of the week I set up tasks and I complete as many as I can. But when those pile up, then they get it all finished on that one day. Otherwise, you can get pretty overwhelmed going from task to task to task. So it's nice to have some structure in your day.
Do you have to take a lot of call?
You don't have to take a lot of call. It actually depends on where you are geographically. Some hospitals require you to take a certain amount of call. It all depends on the size of the call pool and how busy the hospitals are. And so by requirement, I'm not required to take any call whatsoever. But it also depends. There is some financial compensation at some sites and other ones. There is no compensation, and it's just part of a requirement of maintaining privileges. So in the San Diego area where I am practicing, there is no requirement, but I'm participating.
As a surgeon, what percentage roughly of patients that you see in the office are you actually ending up doing surgery on?
The goal is close to 100%. I've seen surgeons who are well established, and basically they are turning patients away. You want to get to that point in your career where you are selecting patients who are the most appropriate that you can exercise and perform the best surgeries for the best results, and identifying patients who are not good candidates and telling them that they are not appropriately going to be a surgical patient. Initially, it's not in that ratio. It's a lot of patients are coming in and they're getting educated. And then I enjoy that. I spend over an hour in my consultations with my patients, and not for the point of pushing them or encouraging them or coercing them into surgery, but to give them all the facts and the raw details, the scary things that can happen in surgery, so they can make an informed decision. So at this point, I don't feel that half of them are going to the operating room because they're just still in that information gathering stage. But as careers progress and you become very well known for particular surgeries or techniques, a lot of patients coming in having already done their homework and research, especially with the availability of resources on the internet. They've done their background on you. They know where you train. They know what technique you do. And they've come specifically for that technique or procedure. And that ratio of conversion is much higher.
So probably not the best question for somebody that's brand new in practice and trying to get established, but what does your work-life balance look like? Do you feel you have a good work-life balance?
I have a good work-life balance when I choose to have a good work-life balance. And that is very different from a lot of other physicians who are at the beck and call of their pager or their schedule, and therefore they don't have the same freedoms I do. So I can choose to work incredibly long hours, or I can choose not to be working those hours based on my specialty. There are still emergencies, and so I won't operate for weeks before I go on out of town, out of the country on vacation. But that's the only limitation, honestly. When I can choose within my personal setting to take time off to tend to myself, to my health, maintaining. This is the first time in my life I'm making regular appointments to my own physician and catching up and getting blood tests and doing those things. But I'm also participating back in community, volunteering, and spending time with my wife, which is all those things I think are very important, and a higher focus with younger, newer doctors, and I think that's beneficial for a more long-lasting career. The idea that you can just go out and just work, and see as many patients as you can, and there's value to that. But when you start sacrificing your own personal health, your interpersonal relationships, then you're not going to be as healthy of an individual, and therefore not a good doctor over the long run. You're just going to get burned out, and that's an increasingly common phenomenon. You hear about, not, you're not talking about cardiothoracic surgeons. You're talking about all specialties doctors burning out, depending on their situation, by not, maintaining themselves. So I think good diet, nutrition, exercise, health maintenance, time with family, downtime are all things that should be scheduled and consciously part of your day-to-day, instead of things that are added on as if you have time.
What does the residency and fellowship path look like for somebody in your position?
It's pretty standard. Basically, out of medical school, you'll be applying. Before you graduate, to a otolaryngology head and neck surgery residency. It used to be an early match, and for many years now, it's on time with everyone else's all the other programs. Essentially, it is a 5-year program. It does have an intern year, but it's considered an integrated intern year, typically at the same institution that you're doing residency. It does have general surgery components and rotations, but however, increasingly more focused toward an ENT residency. So the elective months will be anesthesiology, you'll be in the ER, you'll be doing surgical ICU, all geared toward your skill sets that will be beneficial for your residency, versus a standalone general surgery year where you are on rotations that are purely dictated by the general surgery department. And that's commonly seen in orthopedics and other surgical subspecialties. And then 4 years of ENT training. And so, and that may involve time at a children's hospital, at a VA institution, may be a research block. But in a sense, you'll be rotating through different sites. And every year you're increasing your skill set. You're learning about all the systems, the ear, the nose, the throat, the different types of surgeries, seeing patients in clinic, and operating as well. But as you go through each year, your level of responsibility, and then as a chief, you'll be running the service, teaching and mentoring junior residents, and at the same and before you graduate, you'll apply to a fellowship. So that's typically within your 4th year. There are a number of fellowships you can pursue: pediatrics, neurotology, head and neck cancer, with microvascular reconstruction, facial plastic reconstruction, sleep medicine even. And so during the 4th year is an application that goes in around March, January through March, and you interview between March and end of May. And then you'll match to a fellowship program, and that's for 1 year that will go after your graduation from your ENT residency.
With your current specialty, isn't there another path to get to where you are outside of ENT? Like if I just wanted to just do plastics, could I be a facial plastic surgeon with just a plastic surgery residency?
Yes. If you wanted to just do plastics in the face area, you could definitely reach that goal through an alternative route, and that would be through plastic surgery. There are, and I'm not 100% certain because I've done it myself, but there are 2 pathways through plastic surgery. One is to complete general surgery and then apply to a plastic surgery program, and then there are also integrated plastic surgery programs that that you match right out of medical school, knowing you're doing plastic surgery, and that has a general surgery component to it. Those programs are typically longer, with research years as well. I believe lasting as long as 7 years to finish those residencies. And then most individuals who want to operate in the face area will go ahead and do an additional fellowship on top of that. So you can reach the same goal in a sense, the same practicing setting, but you'll additionally have other skill sets bringing to that job as well.
How competitive is matching to ENT and then I guess to facial plastics?
ENT has gotten to be one of the more competitive subspecialties to match. I think all of the surgical subspecialties have gotten difficult because it's just a pure numbers game. Just from any type of academic application, kids are applying to more colleges. College students are applying to more medical schools. Medical students are applying to more residencies, and so even when I was applying, I've met people who applied to every single ENT residency in the country just to play the numbers. And so that means more applications on the residency director's table to leaf through and make a selection. And so we only have a pretty small program. Only 2 residents are accepted per year. And I'd say maybe 30 people were applied per spot. It may be more, maybe less than that. Some programs only have 1 resident. Big programs have 4 to 5 residents. And although some may say 30 people may not be a lot, but each one of those individuals have published research, a phenomenal USMLE Step 1 score, letters of recommendations from chairmen, have done research rotations, have really stacked their binder full of accolades. And, I started thinking about it in my clerkship year, but, a lot of the junior residents from my residency program, they were thinking about it from their first year of medical school. And there's now an ENT student interest group that starts guiding students from the first day they get to medical school. And so it has gotten increasingly competitive to apply to any of these residencies. And ENT, I feel, has a popular swing recently. It had a big swing, before I applied, but it's always been up there along with the other type of surgical subspecialties that remain competitive to get into.
What should a student be doing to be a competitive applicant?
Well, it's all the basic things that everyone is always striving for. So, maintaining good grades, regardless if you're a pass or fail system. Getting into AOA as another marker on your curriculum vitae that's showing that you stand higher in your class than other students. But then after that, and the USMLE Step 1 score, after that, it can mean, you can have a unique focus in a sense that before it was just about generally trying to get in some research and project, but if you can get on a research project that is related to the residency that you want to apply to, that can only help more. Publications, participation, posters, presentations, attending meetings, getting involved in the department, attending conferences, because there's always academic conferences every week within that department. Just making a personal connection with the attendings in that department. All of those things can make you more visible and create a level of investment from those, not necessarily to get you accepted into your home school's department, but also, they may be invested in getting you into, their alma mater or another program that they're aware of that would be a good match for you, or a geography that you're interested in. So it is a time investment. It is because you're spending so much time already studying and trying to do all those basic things. But by investing yourself personally, that will, I think, give you an additional edge. But there's also a gamble. I know people who've done that and then decided they want to actually do a different specialty too. So you're not locked into it. But if you know early on, that'll behoove you to create that rapport, create that link to those individuals early. and so they can really get to know your medical school your career.
So there, in the world of medical schools and graduates, there are a lot less osteopathic physicians graduating. Do you see many osteopathic facial plastic surgeons out there?
No, there are very few osteopathic ENT physicians. I've interacted with some. They're all great. Within the world of facial plastic surgery, it is still a very small community, and I think the majority are going down the MD path, and so overall I've seen fewer. However, the individuals operating in the head and neck facial area is growing. I mean, there are oral surgeons who perform cosmetic facial plastic procedures. There are, of course, general plastic surgeons who do those. There are those in the field of oculoplastic surgery who want to do facelift and rhinoplasty. There are dermatologists who want to do more surgical procedures in the face. And so, and then there are general surgeons, other surgeons who take cosmetic courses and get boarded under the Board of Cosmetic Surgery and perform those. So there are an increasing number of individuals out there who have not gone down a traditional path of training and are performing those procedures.
You talked a lot about some of the subspecialties out there. I don't know if you remember which ones you talked about, but in general, what are the opportunities out there to subspecialize after ENT?
After ENT, there is a phenomenal opportunity to subspecialize, not only by pursuing a fellowship, but also, I mean, many departments are strong in all fields within otolaryngology, and so it's not a necessity to have a fellowship training because it's not as formal. There isn't a required board certification for all the subspecialties. Not all of them are ACGME certified either, and so you can pursue a fellowship in facial plastic reconstruction surgery, head and neck cancer with or without microvascular reconstruction, pediatric otolaryngology, otology or neurotology involving ear surgery, sinus rhinology, laryngology, professional voice. I feel like I'm forgetting one, but you can do fellowships in those. But if an individual has graduated and they've had strong training, and they can go out and they can become a subspecialist, they can focus their practice doing laryngology and professional voice in an area that needs it, and provide that care at that subspecialty level without fellowship. As long as they're adequately trained and they have a desire to pursue, those patients. And so, but that's a rarity. Most times, even those who are really focused, even, nationally known for a particular field, those guys are always interested in doing other aspects of ENT as well. Some are doing more trauma. Some are, they may be doing head and neck cancer. They may be doing endocrine surgery, but they're known for voice. They may be filling other roles within their group practice, and so most of the otolaryngologists that I've met often miss doing other aspects, but find that there's someone else who's stronger in ear surgery, so a lot of the ear cases go to that surgeon within the practice, or someone else that really enjoys sinus surgery, is savvy with it, is up with the latest techniques, and so that practitioner, when that group, will see more of those patients. But each and every one of the ENT doctors in that group is less likely to solely focus on a subspecialty and only do that. Most of the times they will be a little bit more well-rounded and be doing multiple aspects of ENT, but not necessarily all of them. That just it's getting tougher and tougher to be an overall generalist unless you're in a more remote area and there's fewer practitioners around.
What do the boards look like for you?
The board exam is there is a written and an oral exam component. The current format are separate examinations. At one point in time, they were done on the same setting, but currently you will take the written exam. It is a computer-based test that is administered in September following your June-July graduation from residency. And that is a multiple choice format test that tests all of your all the aspects of ENT medicine and surgery. And there is a pass-fail threshold for that test, and those who pass may go on to the April exam, where currently administered in Chicago. And right now, I believe there are 5 rooms with a number of 3 or 4 modules in each one, and it's basically a mock simulation clinical case. They're integrating some technology, CT scan. They used to give you photographs, but now you can get a computer screen and you can flip through a couple of slides of a CT scan or lab tests or histopathology, and you run through a case from the patient presents as a child or an adult who had a car accident or someone who's lost their voice. And then you ask questions, you proceed through the case and answer. And you gain points based on your questions and responses, and they tally those up. And then once you've passed both of those components, then you're board certified for 10 years. And then through that 10 years, you're doing maintenance certification through online modules every year. And then at the 10th year, you're recertifying again. So that is the board certification process for otolaryngology. You can also get board certified in neurotology, sleep, and facial plastic surgery. And those consist of both a written exam, an oral exam, and in some cases, collecting case reports of patients that you've operated on in the first couple of years of practice.
Do you know what the pass rates look like?
The pass rates are pretty high for both exams. I can't give you a number though, but I'd say I think less than 10% fail because there's quite a bit of preparation for these exams.
What do you wish? It's a little bit harder, I think, for facial plastics. A general question I ask: what do you wish primary care providers knew about your specialty to better help you do your job? But I'm guessing that you don't interact much with primary care providers.
I still do when I see more for the general ENT type patients. That's I don't know if this is much of a tangent, but I used to give a lecture to family medicine residents about HIV manifestations in the head and neck, and it's shockingly common. And this is from sores on the lip to frequent sinus infections to ear infections, skin lesions, lots of different changes that present in this head and neck area, and a primary care can pick them up if they're looking for them and make the appropriate referral for both HIV specialists, infectious disease specialists, as well as an ENT doctor to get involved. And so that's one of the things I think that can be missed, and it frequently is missed, but then can be detected and really initiate early care in at that primary level.
What other specialties do you work the closest with?
It depends on me personally. There be dermatologists if they're removing skin cancers. That's probably the closest in my personal practice. However, there are a lot of ENT specialist surgeons who work with The head and neck cancer doctors will interact with medical and radiation oncologists. The ear doctors, the neurotology range, will interact with neurosurgery for skull-based surgery. And so in the intensive care unit, if you're doing larger surgeries, the head and neck cancer surgeons will see patients that get admitted to the ICU for laryngectomy or tracheostomy management. But interestingly, a fair number of patients are generally on the healthier side, and a number of procedures we're doing are for improved quality of life, for better breathing, better functioning, and so there's a close connection with ENT doctors in general with primary care doctors for sure, absolutely, and oftentimes there's a unfair and sort of inverse ratio. There's tons of primary care doctors, and you get a lot of their patients into ENT specialists, and there's just very few ENT doctors available. And even with jam-packed schedules, there may be months-long waiting lists. So that interaction, but all the time I'll talk to primary care doctors who, really need to get someone in urgently, and we'll always make our best effort to get those in, and not have them on the wait list.
Are there any special opportunities outside of clinical medicine for facial plastic surgeons?
Outside of clinical medicine, well, I mean, if you're talking about research, there's always lots of research going on with the basic science level, looking at wound care and tissue healing, in addition to these types of different injectable products, hyaluronic acids, botulism toxins. There's a lot of these things called PRP, platelet-rich plasma, and other types of different materials that are being injected in for stability, safety, efficacy, and improving them. And so there is a number of possibilities to pursue research and development of these types of products. As for, I know a lot of, and this can go to any specialty, physicians who get interested in other aspects, they become more interested in the business side, become chief medical officers for healthcare-related corporations. There's actually very small and probably should be more encouraged politically active doctors. There's Dr. Silver down at Atlanta, Georgia, who had a fellowship, a very active surgeon who's gotten very active more in the political environment and stage. And so I think there's always lots of different opportunities that you can springboard from your specialty, especially when you get to interact in both. You could be in the private or the academic setting, and you can take that and translate your practice, and you're going to have to sacrifice clinical time, but there are a lot of different opportunities based on what you're interested. But there is always, you're going to give up that patient interaction, and that normal typical doctor schedule, but maybe it's for more regular hours for when you're becoming a executive in a corporation.
What do you wish you knew before going into facial plastic surgery?
I think one of the major deficiencies in a doctor's education is the business side. At Tufts Medical School, we had a great health professional MBA integrated program that really and didn't really hold you back from graduating with under 4 years. But and I didn't participate in that, but I think it should be part of more of the regular curriculum, as this business side can really, if you have a poor understanding of the business side of medicine, there are great doctors that can no longer practice because their practices get shut down and closed, and other individuals who have some phenomenal skill set and need to get out there, if there's this barrier that they can't set up their business or they don't think it's possible, or even, you don't necessarily have to be a small business owner, but as a component within even an academic group or a multi-specialty group, if you don't understand the metrics of and the financial side of it, I mean, again, you can't practice effective medicine if you're running at a loss and your clinic gets shut down, and then what happens to all your patients? So I think that business, the economic side of medicine, really needs to be a core component in addition to biochemistry, genetics, anatomy, and physiology, because it's inevitable. Medicine has become more and more a business. It may not be desired to be that way, but it's a reality. And physicians really need to understand how to run it effectively and how to protect their business so they can continue to give great care to their patients.
What do you like the most about being a facial plastic surgeon?
I love the fact that I have the ability to look at something that a lot of people think they understand well, and bring just another level of understanding, another level of treatment to it. So, for example, when people talk about breathing through their nose, someone say, well, I can't breathe through my nose well. And that may divide up between somebody who's like, well, they have allergies, so it's swollen and stuff. The people's like, well, there's something structural going on. They have a deviated septum. And that alone takes a higher level of understanding of nasal physiology and the anatomy and diseases that affect it. But a lot of really well-trained people will stop at that point, and they may treat the allergy, they may fix the deviated septum, and the patient still has a breathing problem going on. And that's where I come in, and I really love understanding the true nuances of the facial structure, because having that ENT background gives me the understanding of all the functionality, all the moving parts, all the components that need to work day to day and be normal. But in addition, that additional training in facial plastics gives me the side of the aesthetics, but also the skill set to create that structure to improve the functionality while maintaining overall normal look. So some of my best results are noses that have just gone away, in a sense. The patient no longer notices that it's stuffy, or they have difficulty breathing through it when they exercise, and they no longer stare and in the mirror and look at their nose that they feel is so prominent, and some people, it feels like it makes them ugly. And so the greatest success is, and terrible for branding, but for patients to have their nose essentially disappear, that it just is in harmony with the rest of their face. It's still their nose. It's not a beautiful or fantastic looking nose. It's just their nose. And the fact that they don't even have to think anymore about picking up a spray bottle or an allergy pill and the structure, because their nasal passageway is nice and open, and so they just go about and they do normal tests every day without a thought in their mind. And so that's one of the pure joys of doing it right, that I notice it, I know what's going on in there, but that patient no longer has to worry about a thing anymore.
On the flip side, what do you like the least?
I think trauma is tough. I think there's a great opportunity to really make a major improvement. Someone breaks their jaw, or shatters their eye socket, but there is it's kind of a limit of what the end result can be, because the nature of the original trauma. You can always make improvements, but you can't really get them to a truly better place. And in addition, I think there's a major psychological component related, to trauma. And so even with a improved physical state, that mentally there's still a deficiency, there's still a pathology going on. And so I don't feel personally within my skill set, to really get a patient really improved. I don't know who does really. I think there may be a multi-specialty kind of care type of thing to really get someone who's come back from major trauma to really get them healthy again, because mentally or physically there are just limitations from just those who were the initial insults that they can't really get back to their baseline.
If you had to do it all over again at this point, would you still choose facial plastics?
Absolutely. I love what I do. I'm excited to get up every day to go and see what comes through the door. It's still, and I think it'll stimulate me for years and years. Interesting enough, if I went out and won the lottery, I would be able to, definitely keep my practice running. But at the same time, I would look for other additional skill sets. I would, check out neurotology fellowship, other things that would complement, what I already do. Maybe get into facial nerve reconstruction and therapies and that, and the advanced side of that. So it's always fascinating. It's always interesting. There's always more to learn from it. And so I lucked into the path, and where I ended up, and that was truly blessed to do that. I could have gone a lot of other ways, and I'm sure it would have been fine. But if there were given the opportunity, I would go about the same. I would pick the same residency, the same fellowship, focused on the same things. Maybe small little tweaks here and there, but overall, that same path has been really beneficial for me, has really played to my strengths, has given me the skill set to be a successful practitioner.
Do you see any major changes coming to facial plastics, whether that's technologies or just fundamental shifts in the way things are practiced?
Oh yeah, definitely, for sure. The advent of social media, a lot of people are becoming aware of new products, new technologies at a much faster rate. The initiation of that first treatment is getting younger and younger. There are 20-year-olds getting Botox to prevent wrinkles. There are people getting surgery at a younger age. But the largest kind of shift going on in a lot of focus on non-invasive therapies. There's energy devices. There are injections to dissolve fat. But I think there is a little bit of an oversell on those types of anything, gets marketed as quick and easy. And then when they add it as cheap, quick and easy, those results don't, in my opinion, ever really, match the promises of the outcome that you get. They're often short-lived. They have unforeseen complications. They affect your ability to do things later. They burn bridges in treatment pathways. So, for one of the things is injection rhinoplasty. People are putting fillers in their nose, but fillers in the nose in that skin area don't behave as well or in the same way as it does in the other soft tissues of the face. And even seeing disastrous things like blood vessels being blocked off and whole areas of the skin and tissue on the nose necrosing. And that can happen in other areas of the face, but wound care, those will heal and with some scarring. But if it happens on the nose or near the eye, then you've lost more function. And so, I think there is this right now, this revving up toward these office procedures, and some are great, but then they're being expanded kind of to use in replacement of tried and true therapies, and so I think it'll surge, and then people will see some of the issues with it, and then it'll come back. But then you can help the improvements of technology. There'll be better technologies. There'll be better equipment. There'll be safer mechanisms out there, and I think for the good. So I think, and that's how medicine has always been. There's always been sort of a pioneering technology or thought or philosophy, and then new techniques come out, and then they kind of push the threshold of risk and complication, and they back off, and then there's a new push as new developments come arise. And but that's how you progress and improve and come up with new therapies for diseases that previously never had any treatment. So it has to be done, but just in a careful way and a more informed way.
Any last words of wisdom for a student that's interested in facial plastics?
Take some art classes. That's what I would say. It's one thing to understand the anatomy, but if you can translate that anatomy and those structures from your brain to your hands, and and using your hands, those are all good basic skills that can translate into being a better surgeon, and even choosing when not to operate. So, always kind of rounding out everything. Everyone will study hard. Everyone will work, to get a high score on the test. Everyone will strive to get that letter. But maybe find one or two things like, sculpting or drawing, or it might be music, something to really keep yourself active, and in a unique sense, to keep yourself motivated. And you may bond with some big name doctor one day who's going to write you a letter based on that unique activity that you do that not everyone else is doing. So I've definitely seen that happen.
All right, there you have it. If you are interested in ENT or otolaryngology, or even the specialty or subspecialty of facial plastic surgery, I hope this episode was interesting to you. I love these conversations. I learned so much from them, even as a physician. So I know that you, as a pre-med or a medical student, are going to get a ton of great information from these conversations to help steer you in the right direction for your career. If you enjoyed this podcast, I want you to do me one thing. Go share it with somebody. Go share it with your classmate. Go share it with your advisor. Go share it with whoever. Go share it on your Facebook page. Actually, this month, as we're publishing this, NPR is doing something called #Tripod, TRYPOD, where they're asking their listeners to suggest a podcast to their friends who don't listen to podcasts. So that's what I want you to go do. Just go suggest listening to podcasts to your classmates, to your friends, to your advisors who may or may not already listen to a podcast. I hope you have a great week. We'll catch you next week here at Specialty Stories.